Welcome, everyone. Welcome. Apologies for starting a couple of minutes past the hour. I'm Sally Davies, consultant editor at Eon magazine, and it's my pleasure to host today's brochure meetup on the ethics of net zero healthcare. So as of today, more than 140 countries have pledged to bring their carbon emissions down to zero in the coming years. Yet these ambitious commitments pose a particular challenge when it comes to healthcare. If the global healthcare sector were a country, it would be the fifth largest emitter on the planet. At the same time, healthcare systems around the world are coming under increased pressure from an ageing global population and the increased burden of chronic diseases. Is it possible to reduce the environmental impact of healthcare or even to make it planet positive without compromising patient care and well-being? Are current ethical frameworks adequate, or do we need to reconsider them in light of the ecological crisis we're now facing? And what responses have we seen so far from clinicians, patients, and other care providers to the initiatives implemented for promoting sustainability? So against this backdrop, we're going to hear from our panelists who bring perspectives across medicine, economics, and ethics. I'll just do some quick housekeeping. The meetup is going to last approximately 1 hour. In the first 45 minutes, we're going to have a general roundtable discussion, and then in the last 15 minutes, we're going to open up the floor for Q&A. At the same time, please do feel free to drop your questions in the chat as they occur to you. We may pick them up in the conversation, but we'll address them in a more fulsome way towards the end. So I'm going to start by asking each of the panelists to introduce themselves. I should just note that one of our panelists isn't in attendance. We're hoping that he might join, but of course we should be able to have a rich conversation with our current three panelists regardless. So Sandy, I'll just ask you to introduce yourself and talk about your current work.
Hi, so good afternoon or good morning to anyone who is listening. So I'm Sandy Tupeuf. I'm professor of health economics in Belgium at the Université Catholique de Louvain. And as a health economist, I work quite a lot on inequalities of opportunities. But since I spent a lot of time of my career as well in the UK before joining Belgium, I worked quite a lot on the evaluation of drugs or healthcare programs, looking into the cost and their effectiveness.
Thank you so much, Sandy. That's such a useful scene setter. Charles, I'll bring you in at this point.
Hello, everyone. Charles Dupras. I'm an assistant professor in the School of Public Health at University of Montreal, and I'm also the director of the bioethics programs here. My interests within the field of bioethics are quite diverse. I've worked on ethical issues related to the fields of genomics, artificial intelligence. Epigenetics has been my topic of main interest over the last few years, and this has made me think about the importance of the environment for human health. And I guess this is where I come from to work on this topic. And together with Valentina, who's working under my supervision as a bioethics students in our programs, we're starting to tackling these challenges. And this is what is really of interest to us. Not only advocating for greater consideration of the environmental impact of healthcare, but also trying to look at the challenges that emerge in these sensitive discussions.
Thank you so much, Charles. And Valentina.
Hi, everyone. I'm Valentina Dumek. I'm currently doing my PhD under the supervision of Charles. Like he said, our research focuses on identifying, exploring the main challenges, mostly ethical, to adopting sustainable practices within the healthcare sector. And as he explained, we're not just addressing the need to reduce the environmental impact of care, but trying to explore the practical challenges that emerge when putting these sustainability efforts into practice. Thank you.
Thank you all so much. Well, look, we've got a lot of ground to cover today. I think that I'm going to sort of start with maybe some naive questions that hopefully we can use to kind of delve deeper into the issues. I think one immediate question is kind of, why is it so controversial or so unusual to talk about net zero in the context of healthcare, given the state of the public conversation about climate change and the ecological crisis? What has sort of stopped full consideration of carbon emissions and environmental impacts in the healthcare sector to date?
So what I really want to say actually is that The problem you will have here is actually that you need a certain monitoring if you want. So when you're talking about net zero, you need to know actually how you're doing at the moment in terms of practices in healthcare. And so as a health economist, I would say that actually when we started actually talking about cost, as well as, cost of healthcare and how much does it cost to cure or provide care to people, I believe that actually that was a very difficult discussion that the health economists, I would say, of 30 years ago were having probably with policymakers as well as with doctors. And I would say now it's completely standard practice actually to accept the fact that taking into account the cost of healthcare is important, mainly related actually to the very well-known concept of cost of opportunity. The opportunity cost of doing something is actually that resources are not available to do something else. So now moving actually to this net zero objective in healthcare becomes a bit similar. It's, why do we want a net zero? And the reason why we want it is actually that if we want to last on the longer term, both from a climate change perspective, but as well actually in terms of planetary boundaries, then actually we will have to reach some targets. And those targets are there to facilitate, the care for all on a larger scale, as well as actually avoiding to lead to worse healthcare or to worse health status in terms of individuals. So I really think, here the dilemma starts because you have different dimensions. First of all, you want that actually healthcare treatments are improving the health of people or allowing them to live longer. So survival as well as quality of life. Then you start saying, oh yeah, but actually we need to be careful with the money we put into it because actually the resources are limited. And now we're saying, actually, we also have other types of resources that are not the budgetary ones, that are not the staff one, but are much more related actually to how do we deal with the environment and how do we deal with our planet that actually matters. And so it's adding, I would say layers in terms of the difficulties that we will have to face, which in the end, comes back to what is the care that actually we are allowing ourselves to do or not to do.
I mean, I think it raises this really interesting question to sort of hear you talk about planetary limits as kind of another resource constraint alongside the more familiar kind of economic resource constraints that we're used to bringing into conversations about healthcare. I mean, I think, a question I have in this area is this a situation where we have to balance or trade off the short-term benefits of achieving certain healthcare outcomes against the long-term considerations of environmental or ecological preservation? Or rather, is it a situation where those two goods need to be integrated because, of course, our well-being and health as a species does depend on the planet as well being sustainable? So I'm curious to hear from the panel about, is this a situation of understanding trade-offs, or is it about reconceptualizing what we think health is to encompass our planet as well as our species?
What a great question. I don't know, Sandy, do you want to?
No, go ahead. I know you want to talk about this.
Well, I think that you've pointed to I guess the multidimensional aspects of health. We can look at the direct benefit of treatments that are implemented to cure patients, but also to look at the preventive approaches to the prevention of diseases, and these have different time ranges, right? And these are sometimes difficult to weigh against each other, not only because sometimes there are also emergency situations in healthcare that really call for an immediate intervention. And in these situations, if you have already experienced one such situation, you would realize that well, your environmental concerns are really far away in your mind, because when suffering kicks in, obviously the more long term effects of the healthcare that you are needing will be far in your mind. There's I guess beyond that time consideration, temporality consideration, there's also the as we said, the multidimensional aspects of healthcare, and the multidimensional I'd say value of also health technologies that needs to be taken into account. As you may know, health technology agencies all over the world are starting to consider adding an evaluation, the assessment of the environmental value of healthcare in their assessments of the global value of health technologies. And so that means not only considering the potential benefits of the technology for the patients, but also the cost of the technology, the economic costs, but also the side effects, also the environmental cost now, because we know that it has indirect effects also on health, and only that per se it is an important concern or important thing to consider to meet the net zero targets. So this is, I guess, a change in culture in health technology assessments. And not only does it need us to consider new frameworks, as you mentioned earlier, new metrics as well in our assessments of the global value of healthcare technologies, but also evidence. We need data to make sure that we can actually do that assessment and weigh the different dimensions of or different types of values of the healthcare technologies we're assessing, whether it is the risks, whether it is the benefits to us humans, but also more globally to planetary health.
Yeah, that makes sense. I mean, this ties into the comment you made earlier, Sandy, about measurement. I wondered if you wanted to jump in here at all.
Yeah, so what I wanted to add, and I think, so if we're thinking about this kind of evaluation, usually as an economist, the perspective will be the welfare analysis. So you're looking into the welfare that actually is gained, from choices we're making, and very often you have competitive choices. And so choosing one over another one is saying that actually the one that you choose bring, higher, in economics we would call it utility, but brings, a higher element into it that actually we value more. What you were leaning towards here is actually the very well-known concept of externalities. There are some positive and there are some negative externalities. And so, when I was talking earlier about the boundaries that actually we're reaching here, that we want actually to make sure that everybody benefits from it. Of course, there is this direct and indirect element that you were talking about. The fact that actually, maybe we have, and I think Charles did it quite well, but at some point we have someone with a very high need of healthcare, and so providing the care, for this person is an urgent need. But then on the other hand, if providing the care, will lead actually to other health issues, and then it's actually important to have them on board, which can concern the individual himself, so, like the adverse events, but which can also have an impact on other individuals, from the same generation. But what we have here with, I think, the level that we're putting this environmental impact to is also different generations of people. And the resources, the way that actually this, let's say, planetary limits, concept is bringing is also thinking about future generations. And the fact that actually some resources might be lost and actually never, gained back, for the next generation. And so it becomes even harder, I would say, in terms of the metrics, because at the moment, the way we're evaluating the causal effect of a treatment or a program is extremely limited, in terms of time. So what you were saying about the longer term impact, but also extremely limited to actually the current population who is living and not those that are coming later on.
Yeah, it's fascinating. I mean, it makes me wonder, bringing in health economics and economics frameworks. I mean, in some circles, there are, alternative economics theories emerging in response to the ecological crisis, things like degrowth economics, kind of questioning certain basic tenets of how we approach economic thinking. And I'm just curious to know, do we need, is there space for an equivalent when it comes to healthcare? Like, what does the degrowth movement in healthcare look like? Does it mean accepting limitations in our present well-being for the sake of preserving future generations? And it comes back to your point, Sandy, about kind of trying to capture multiple generations rather than just focus on welfare and utility for the present generation.
Yeah, so I think, there are two movements that actually are more and more present. The first one is deprescription, so deprescribing. And so, and I think behind this, there is the other elements that actually we would call the low value healthcare that is provided. So if you take, for example, and I'm part of a project here in Belgium on this, which is also in a larger European project, which is about benzodiazepines. And so in general, patients should be prescribed benzos on a very short term. And, you know, I'm not a doctor, so I don't know exactly how long, but I can tell you that it's counted in months. It's not counted in years. The thing is that you end up, and especially in aging population, with a very high level of actually prescription of benzodiazepines that are actually renewed because of sleep issues or other types of issues people may have. And then in the end, you know, it's neither good for the patients, neither good actually for the planet. And so in terms of thinking, you know, about those elements related to deep prescription, it's not about not providing care to people, it's actually providing care in a different way. And the benzo will never sort out as well the main issue that actually the person may have. So, you know, behind thinking in terms of actually the practices in terms of drug prescription, then actually we may get a better common good with actually stopping to do low value healthcare and thinking much more in terms of actually providing the appropriate care, you know, to patients.
So I think that's really interesting, because one of the things I wanted to pick up was whether there are frameworks here that allow us not just to think about externalities and costs, but whether actually there's a bit of a, you know, can we sort of get a 2-for-1 in reframing the way we think about healthcare? Is it possible that we both improve healthcare outcomes conceptualized a certain way, as well as improve planetary ones? But before I think we get to that big question, I just want to ask quite a sort of concrete one. I mean, you mentioned that the overprescription of benzodiazepines, which I understand are kind of an anti-anxiety drug, a class of depressant, you mentioned that it's not good for the planet, that they're overprescribed. I'd love to just hear from the panel about what are the vectors by which healthcare affects environmental health. I mean, the most obvious is kind of the production of technologies and drugs and, you know, gloves and surgical equipment. All of this has an environmental cost in terms of emissions. It certainly has an environmental cost in terms of the fabrication of materials such as plastics that don't biodegrade. But I mean, in what you were saying, Sandy, I mean, I was curious to know, there are other vectors by which healthcare has an impact on the planet that are a bit more unexpected. I'd love to hear a bit more from the panel about those examples.
So unexpected, I think, you know, you will think about all the expected, you know, related to the trajectory of care. So in some of the work we've been doing when we're looking into how actually the environmental impact were taken into account, it was about waste use, it was about energy, it was about incinerating actually waste. So all those elements that are much more, you know, I would say hospital-based type of pollution. But then, you know, when we're talking earlier about, for example, benzodiazepine or actually drugs, then actually you will have the whole life cycle of the treatment, which may as well, you know, create pollution. So from actually the generation of the drug, you know, the way it's produced, and then actually how it's used, and then how it's assimilated, and then actually how it's eliminated.
The supply chain is usually pointed out as being a really important contributor, as well as the basically the transportation of the technologies and drugs.
I mean, it's interesting, isn't it? Because in the kind of mainstream technology sector, there are movements around like kite marks for different technologies that show that the companies have sort of considered the full life cycle, not just the production costs. And it sounds like, you know, those are the kind of initiatives we need to see more of in the healthcare sector. I'd actually like to bring you in at this point, Valentina. I mean, we're kind of talking quite concretely now about, you know, what does this look like in healthcare settings? I mean, I know that, you know, some of the research you've been working on with Charles is kind of examining the social acceptability of how sustainability initiatives are perceived. I wonder if you could just talk a little bit more to that and kind of the preliminary findings about, like, how is it when you talk to clinicians about the fact that they need to consider the environment when it comes to doing their work?
Sure. So, sorry, assuming it will be necessary to better assess and understand patient and professionals' preferences, what they're willing to compromise, to reduce, to do in their practice, and so on. We conducted a real-time Davies study. Maybe Charles can say a few words on the method later. But basically, we consulted experts about the potential positive impact and the level of feasibility they attribute to sustainable interventions in healthcare related to education, infrastructures, norms and values, energy, storage, and production, but also what obstacles or ethical issues they perceive implementing them. And one of the biggest hurdles identified by the participants was that these interventions often required large-scale systemic changes. They talked about significant investments in infrastructures, adjustments in to energy use, and also I think Charles said it, but like shifts in standards and culture. The reality they highlighted was that healthcare facilities could not really operate in isolation from the systems they rely on, so like energy grids, building codes, and that the pace of change in these areas are often slow, and naturally that affects how quickly sustainable initiatives could be implemented in healthcare. Another recurring theme was the just-in-case mentality that healthcare professionals operated under. That was a deep-rooted concern in the answers about compromising patient safety, which made sense. Like no one wanted to be responsible for under-preparing or cutting back on resources that might be needed in critical situations, even though they mentioned that some sustainable practices did not impact care quality. The perception of risk remained like a big obstacle for them. Education and engagement in general, public, political, professional engagement was also like cited as key areas of focus. They mentioned that they were facing high demands already, and that integrating sustainability into their everyday practice will be challenging and was challenging. There was a fear that doing so could detract from their ability to deliver high quality care. And they pointed out, as we did, a lack of sufficient data on the environmental impact of specific healthcare activities, and that a clear picture of the environmental cost of everything was still missing. Lastly, transparency was another key challenge. Like participants noted the need for better information about the environmental footprint for pharmaceutical and biomedical companies, but they also emphasized that this transparency shouldn't be limited to the sector. Like patients and the general public also needed to be informed as well, because according to them, like when patients have access to the right information, and it empowers them to make choices that align with both their health needs and also the sustainability goals. And lastly, there was the issue of justice that came up. Like they mentioned that they were constantly navigating resource constraints, as Sandy mentioned. So when it came to implementing sustainable interventions, the challenge was choosing where to focus efforts, like prioritizing areas more vulnerable to climate change, even though they required more resources, was one option, and focusing on urban centers where population density and pollution are higher was another option. But in any case, like striking a balance between these competing needs really seemed difficult, and especially with limited resources. But to sum it up, the challenges it involved balancing patient safety, resource constraints, transparency, equity, and ensuring the continued delivery of high quality care. And the study overall really showed that these challenges require a nuanced approach that takes into account the interconnected nature of the system, like the complexity of the responsibilities and the web of responsibilities. There is also a topic we'll be maybe talking later in the session. But yes, that's the preliminary results of the Delphi study.
That's fascinating. I mean, something that jumps out to me hearing you talk, I mean, there's a couple of things. One is just, I mean, in my introduction, I just mentioned the fact that healthcare systems, quite aside from the net zero commitments, are coming under increased pressure around the world. You know, there's a literature on clinician burnout, and and on top of this, we're now adding this other set of obligations for them to consider. That's quite a tall order, it would seem to me. And I guess this comes back to your point about, the matrix of decision makers, the web of responsibilities. It seems, unfair to put the decision making around sustainability and environmental health in the hands of clinicians. This is probably a decision that needs to be taken higher up the chain, such that the framework within which they're operating doesn't fall to them to sort of decide whether a particular ethical trade-off is worth it. Maybe this is a good point to bring you in, Charles, of course, because your work is really looking at clinical ethics, bioethics, and kind of trying to create a sort of integrated approach with environmental ethics. So perhaps you could talk a little bit to that.
Well, yeah, I think that you're so right in pointing out that there's so many different actors that can be involved in these discussions, but also in the initiatives into really implementing these best practices. You can talk about the need to involve the patients, the need to involve the professionals, people working in healthcare, health technology agencies, decision makers at multiple levels. And really, I think that Sandy was pointed out to something really important, is that we need to not only look at the challenges or the trade-offs that may occur, because this may actually have a negative impact. It may keep us in the current stage of status quo and impede transition toward a more sustainable healthcare sector. So you can look at the real trade-offs, but also try to debunk the actual false dilemmas that are out there, or the just the perceived trade-offs that keep us from really addressing what can be done better in ways that actually make the preservation of the environment and the promotion of human health actually really align very well. In other cases where there are some challenges or tensions or dilemmas, it becomes really important to not only start talking about this between us, but also look at how we can ask and engage with the people who are actually involved in these difficult discussions. Some of the people that I believe are too rarely involved in these discussions are the elderly. We are sometimes, for many reasons, because in qualitative research, it can be difficult to just reach out to them and include them in our studies. But it is so important because they are possibly the main stakeholders, knowing that most of the healthcare environment, the environmental costs of healthcare has been associated to the last years of life and end of life treatments, palliative care, and all these important periods of life where you're at a stage where you're more vulnerable than ever. So we need to be careful to make sure to have their voices spoken out and taken into consideration in these sensitive discussions.
Actually, Charles, could I just wanted to interrupt you there for a moment?
Of course.
2 reasons. One, I just want to welcome Anand, who I'm going to bring into the conversation shortly. But before we do that, I just want to pick up on something you said, because it was very interesting that you think there's a role for kind of debunking some of the false trade-offs that clinicians and care providers think there are around environmental health and patient well-being. I'd love you to just, I don't know, race through a few of these trade-offs that that actually are false ones, and then maybe you could, on the flip side, talk to what are some of the real trade-offs that we actually need to think about, and then I'll bring Anand in to introduce.
Yeah, well, I think that the first that comes to mind was really the one that Sandy mentioned. This whole movement towards deprescription could be seen as if, I'm going to be taking off my medications, and that may involve me not grasping the full benefits of the available healthcare options that are out there. But that's not really the case, right? Actually, deprescribing in many situations will actually lower the side effects of those drugs and minimize the risk also of interactions between drugs. So there it could be seen as there's going to be a trade-off, because the main reason is preventing environmental hazards, but here it's not the case, right? It's like the two motives align very well.
Interesting. I mean, it does strike me too that, you know, one of the things hearing this discussion, I'll bring you in a moment, Anand. I mean, there is also this question in my mind about, given there is also a very lively conversation about global health inequalities, how can we avoid net zero emissions being, you know, yet another way in which the global south is disadvantaged? Because, of course, you know, in the conversations around net zero, there's already this political controversy about the fact that, of course, Western nations are the ones that are primarily responsible for the climate crisis, and yet the burden of reaching net zero is disproportionately falling on the global south. And similarly, I think, you know, is there a question here around, you know, how can we avoid net zero becoming another thing that exacerbates health inequalities? But perhaps what you're saying, Charles, is maybe that's a false trade-off, and there are ways that, you know, achieving net zero forces certain kinds of reconceptualizations that might actually improve health inequalities. So I'll leave that on the table for the moment. Anand, I'm going to bring you in at this point. If you could just briefly introduce your research, and then I'll ask you a question that hopefully also captures a little bit of what we've been talking about so far.
Yeah, so thank you so much, Sally, and absolute pleasure to be here. My name is Anand Bhopal. I'm a medical doctor by background, and I recently completed a PhD looking at some of the ethical challenges that emerge at the net zero healthcare agenda, both looking at this on a conceptual level, but also some of my work was qualitative research, interviewing and speaking with policymakers who are actually working on this. And I was just picking up on what the conversation has just been happening. One issue that really came up was make sure that you're thinking about trade-offs correctly, because there is a risk that you're assuming a trade-off which is not there. And I think that's a really important issue that actually came out through my qualitative work as well.
Well, that's terrific. I mean, I think you know, what we've been talking about so far is, we started with Sandy discussing this, you know, the concept of kind of planetary boundaries and kind of conceptualizing healthcare not as something that just demands economic resources, but one that, you know, imposes that has, you know, limits in terms of what the planet can provide. We've discussed the ways that ethical frameworks might need to adapt in light of the ecological crisis. And Valentina has also, you know, in resonance with your work, Anand, kind of very helpfully, I think, provided some examples of the kind of challenges involved when talking to people who work in healthcare settings, the sort of difficulties and concerns they have around transparency, compromises to patient safety and equity, and so forth. So I think, I mean, this does raise a question for me, which is, you know, I think, back to something at the start of the conversation, we, you know, Sandy and I started this conversation by talking about net zero, but there is also there is this critique emerging within, you know, the environmental literature around this idea of sort of targets not necessarily being the thing that's needed. We actually sort of need normative changes to kind of really drive the transformations that are going to be perceived in healthcare, because telling people that they have a target to reach is perhaps not as motivating as kind of changing some of the norms around how these things are perceived. I mean, as you have said, Charles, this does also require kind of patience to be involved in these conversations, because it seems to me this might require a kind of society-wide shift in how we perceive healthcare, that patients need to be kind of signed up to, you know, doing things in a different way. And I guess this kind of raises a question, you know, practically speaking, how does healthcare look different in a net zero world? What sort of initiatives are we talking about? And are there any precedents for hospitals or healthcare settings that are already doing this and doing it very well? I'd love to hear from the panel on that point.
Maybe I could just jump in first, and I would love to hear what others think. Just a brief general comment first is, that actually the drive for low carbon, net zero, sustainable healthcare is often coming from healthcare workers themselves. And I think this is really important to realize. This isn't something largely being imposed on people, but actually being co-created with. And actually, that's because many clinicians recognize that things can be done differently. And it wouldn't be worse for patients. In fact, it could often be better. There's been many shifts that have occurred over recent decades, which actually people aren't too happy with. For example, the shift to single-use materials in healthcare is actually not preferred by clinicians most of the time. This could be surgical tools or something else. So there's lots of areas that are recognized. And it's important to realize when you think about that across all specialties, all areas, and not just frontline clinical staff, but all people who are involved in procurement, administrative areas. So I think, firstly, this is really crucially to think this is not largely being imposed on. I think it's being built up. So I think just when we kind of bear that in mind, it becomes really important to think, yes, the healthcare workers, clinicians have an important voice, but as you say, so do patients. So it's in this way, I think the qualitative literature, and there has been some which is emerging in this area. There's a couple of studies in the UK. There's some research that's been done by the Health Foundation where they were involving patients, different stakeholder groups, telling them about this program. What do you know about it? What do you think? And actually, there's some quite reassuring things that emerge. And that's largely that if you tell people and explain to them the rationale of what you're doing, actually, most people tend to get behind it. So that's quite useful to know. And I know that the greener NHS work, for example, that engagement with patients has been really important. If I could just add one final thing as kind of food for thought, I think there is going beyond sort of, you mentioned about what does that healthcare look like in a sustainable world or reimagining it. I think this is actually an amazing opportunity to reimagine, because maybe what we should think about is what we're interested in is health. Healthcare is one way of delivering health. We're interested largely in health outcomes. How would we do things differently if we had the opportunity? And I would say it's not just an opportunity, it's a necessity to do things differently. So how do we protect and improve health in that situation? Therefore, it's not flipped. It's often framed in a sort of negative way, but it's things have to change. And how do we protect health along the way? And I think that's some way in which anyone who's involved in health or public health knows there are many ways of delivering health. And healthcare is one dimension of that. Anyway, food for thought. I'm going to put all of that on the table. Thanks.
Charles, I get the sense you want to jump in here.
Yes, good intuition. So I think that, well, there are actors that we tend to forget as well in these discussions, and just naming the pharmacists to me is I mean, we need to start thinking about how they can be involved in sort of dealing with the prescriptions that are made by the physicians, and also the needs and preferences of the people that come to see them to get actually their medications. And one of the things an analogy that I'd like to bring to the table is the analogy of generic drugs, where you have the pharmacists who have the opportunity of proposing generic drugs sometimes to the people, to the patients, to their clients that come to see them. And sometimes they are reluctant to do so, simply because the patients are used to consuming and using certain drugs with particular brands, and they've been using that medication for years. And if you propose a change in this type of drug, which is actually the same molecule, they will start asking, or they might start being concerned a little bit. So what if the pharmacist would also be involved in proposing more or greener options? I mean, that would be an interesting avenue. Only would they need to have the proper information to be able to distinguish between those who have, the same effects, the same benefits to the health, exactly the same clinical effectiveness, but also being able to distinguish which has the lower environmental cost, and therefore being able to propose which is the most responsible avenue or option for the people that come into the pharmacy. And then you also may need to consider also the economic costs. Are we willing for the same clinical efficacy to when there is a situation where there's a lower environmental cost, but a higher economic or financial cost at the same time here, are we willing to pay a little a higher price for a drug that would have a lower cost? So there are some, as you see, possible tensions as well, and not only in the pricing. Let me just give you another example, and this is a topic on which Valentina has also worked. We've studied the particular case of inhalators for asthma and chronic pulmonary diseases, and this is an interesting case because the greener option or the more sustainable option here in this situation is great for most of the population, but it increases a little bit the risk for a certain group of the population.
And can I clarify, Charles and Valentina, why is this option more sustainable? Is it has a lower carbon footprint in its production, or there's a different aspect of the life cycle of the whole treatment that means it has less of a planetary impact? Can you just set out what the two treatments are?
Sure.
Valentina,
Basically, one of them, the MDI, uses HFC gases that contribute to ozone depletion.
Interesting.
That's
Okay.
mostly it. But to come back on that, most of the issues we identified were at the patient-doctor relationship level, but there's also the big global picture to consider, coming back on what you said about the Western world being more responsible about the emissions, because the international agreement on HFC gases reduction establishes different timelines depending on each country's resources. So wealthier nations obviously can transition to less harmful options more quickly, but developing countries may face greater challenges. And this also highlights like the need to balance global sustainability goals with healthcare equity, also across regions, but not just across patients of Quebec, because the case study was based in Quebec, but we reflected also on the international level.
I mean, it strikes me in conversations around equity, there's one worry I have about all of this, which is the following. I mean, for example, there's the well-known critique that the notion of the carbon footprint was actually actively promoted by oil majors because it was a rhetorical device that allowed, crucial actors in driving climate change to deflect responsibility onto individual consumers. And so now we all feel guilty about single-use plastics, when in actual fact, we are embedded in supply chains that were not of our own making. And it's very hard not to be implicated in the consequences of your own consumption. So I just wonder, is there a risk here that in some of these conversations, which I take your point, Anand, I think it's quite heartening to know that actually, of course, doctors and patients and nurses are humans too and want their work not to have a negative planetary cost. But is there a worry that when we're examining questions around, whether or not a particular gas is used in an inhaler, we're not looking at the big picture of kind of, is this more of about the responsibility of like medical device companies to change their production processes? Are there questions of equity about, who actually should be bearing the cost of getting to net zero? And maybe in the first instance, maybe the patients and the clinicians are not the lowest hanging fruit, that we should be going after some of the actors up the chain. I don't know if anybody wants to jump in there.
I may.
Please,
Because
Andy.
what I really think, that's interesting is that a lot of the things we've been talking about are, I would say, local initiatives. So even NHS Greener or actually inhalers will be local ones. But actually, we need to be global here. And actually, sometimes you even hear this concept of global. But what I really think is that if we're looking into the life cycle, of a whole product, whether it's a drug, whether it's a medical device, even actually materials that actually we will find within the hospital, the places where they are, produced is very often actually the one that will not benefit from that technology, and actually that might be as well the large part of the pollution. So you're totally right. It's a bit narrow-minded actually just to look into the impact that actually it will have on local scale. But what I also think, that is interesting, and that's the risk, for example, of what you were saying earlier with targets, is that it's great to have targets, but actually at some point, eliminating things from one healthcare system in a very large Western world will end up actually being sent somewhere else in the world. And this is what we've seen, for example, with pesticides. When we think about pesticides in Europe, actually they've been banned. And so what happened is that you have places like Brazil that actually are full of pesticides because they're still produced and they're still there. And so I really think here that you're right in terms of let's say the equity, the inequities around the world. But I still think that actually on the longer term, there is more to gain, and that means probably one of the SDGs, the Sustainable Development Goals, at a large level. But I think, making people more and more aware is important, but you're totally right. And another actor that actually we've not been talking about here are manufacturers, how actually the manufacturers are changing the way that actually things are produced, so that we turn towards providing the care that people need, but in actually a much more sustainable way.
Maybe
yeah, go on, Anand.
Could I jump in, Sally?
Yeah.
I think that's a really, really important point. Like both you and Sally and Sandy, you both referred to this, the sort of local to the global, and it's kind of recognizing that you need to simultaneously think of and address these at once. And I think this comes back to the sort of mechanisms of the Paris Agreement and the way in which it is different to things that have come before. And that is this sort of polycentric level, this sort of multiple levels of governance, multiple levels of intervention. We can and should apply this on the health system level as well. So there are things that occur on the individual clinician-patient interaction, some things on the facility, some things health system, some things globally. And sort of this recognition that they all kind of need to happen at once. And they have these sort of, self-perpetuating, hopefully positive feedbacks between them. So, for example, there has to be some demand for change from the bottom. But there also absolutely has to be change from the pharmaceutical companies and the manufacturers. Now, I would say actually, thankfully, we are seeing that sort of playing out on multiple levels. So pharmaceutical companies have been interested in addressing these. Similarly, there is a drive from clinical level. But I think this is a really important risk to be aware of, that the carbon footprint model and thinking about this on an individual level to such structural problems is really could be misguided. As Sandy alluded to, the supply chain is huge. If we just talk about carbon emissions, that's roughly about 75, 80% of healthcare's emissions come in the supply chain. So these are hugely structural and difficult problems to address. And this sort of displacement risk, you deal with it here, but the problem just gets shifted. That's not sufficient. And I think this is where a wider view is absolutely crucial.
I think there's also a question here around the disconnect between how these frameworks and dilemmas are understood by researchers, even policymakers, and then the extent to which they can be implemented in practice by politicians. Because it seems to me that to really grapple with this, politicians need to be willing to have a kind of social dialogue with their electorates about the meaning of health. And that, as in many places, that is an extremely difficult thing to do, because people don't really like to think of health as being a kind of finite thing, or something that we need to trade off with other things. So there's this sort of denialism around the realities. And I mean, I take the points that several of you have made that, some of these trade-offs are not real. Some of them are sort of bogeymen or fears. And actually there are, Anand, to your point, it's very interesting to think that, healthcare, there are many causes of health, and what we think of as healthcare traditionally is just one. And actually, by expanding the notion of health, thinking about it in terms of, social prescribing and all sorts of other ways that we can improve people's well-being, is actually good for the planet and good for patients. Nonetheless, I sort of want to push the panel to like really talk about where are the real dilemmas, you know, where is the rubber going to hit the road on this? Where are the real things we're going to have to say, you know, we might have to give up on this outcome for the sake of achieving a more sustainable healthcare system. I'm really curious to hear where, I mean, maybe Charles, you want to come in there, or Valentina, kind of what are the present most pressing dilemmas in terms of moving towards a more sustainable healthcare system?
Well, I think that my reaction to that question would be to challenge you actually, and try to say, well, is there such a thing as like is this really where we need to go? Are there any kind of treatments that we will need to, you know, move away from? I don't think that's really the framing of thought that we want to get in. I think it's better to ask the question, how can we do better, right? That's the general framing which I like to sit in. Not saying that there aren't you know, some approaches that may not be a priority. We've all mentioned the supply chain and you know, the dependence on fossil fuel. Just fossil fuel is immense territory where we can do better, certainly. But I like to think of about those trade-offs, not in terms of what we're going to lose, but how can we minimize actually the sort of the compromise, the idea that we're going to be making a compromise. That's not really where we want to go. We want to sort of try to better align these motives that are actually sometimes confront or conflict with each other, but we are innovative enough or creative enough that we can think of solutions to do better and achieve both goals.
I mean, what I hear you to be saying there, Charles, is sort of making the pragmatic case that it's not going to really help get people on board if we sort of frame it in terms of trade-offs, and so it's more politically useful if we kind of think about the, you know, the plus. I mean, I should say we're coming to the last few minutes of the session. I've been monitoring the Q&A, but they've just got a couple of points maybe we can pick up. Someone's made the comment that the short-term health benefits of reducing fossil fuel use are attractive to politicians whose constituents receive short-term benefits, despite the fact there, you know, may also be other dilemmas. I think I will pick up on another comment here, or another question, which anyone is welcome to jump in on the vectors of how does better health and longer living populations negatively impact the environment? Would we or should we internalize this variable as well? Does anyone want to pick up that question from the attendees?
If I may, from a health economics point of view, but actually much more in terms of resource allocation, this is actually a question that actually has been very dynamic, I would say, with a lot of philosophers, you know, on actually, shall we, for example, provide resources to someone because actually they have not had their fair share of life, so actually living long enough, instead of actually giving it to someone older, you know, shall we actually make sure that actually people, you know, all have a chance to live up to the age, I don't know, of 60, and then having resources differently. So I think, you know, here we will struggle, I think, to find an agreement on that, because when we saw, for example, the COVID, you know, pandemic that we had to face, in the end, the way that actually we had was we were fighting against death, you know, in a way independently of how long people had been living. So we gave value to survival much more than actually, you know, the quality of life, which in the end we ended up locked down in many countries. So I would say, you know, that it's true that potentially, you know, the higher costs in terms of healthcare are coming indeed, you know, with cost at the end of life. And I would come back to the point that earlier Charles made, you know, about palliative care, or actually other types of care that could be provided in a different way, you know, that may no benefit, you know, to people, I would say, in terms of living well, long lives, you know. But I really think that here there will be other dilemmas in terms of actually who should get the resources first, whether we're talking about environmental resources or actually financial ones.
Yeah, I mean, look, it's very interesting. I'll come to you in a second, Anand. I mean, the palliative care and end-of-life care, I mean, there is obviously a big discussion around how that can be done better instead of this sort of scramble for multiple interventions to prolong life at all costs. Actually, we need to reconceptualize the way people think about their lives and value their lives and reconsider end-of-life care. And that would, of course, have a likely benefit of being less resource intensive as well as yielding better outcomes. So that's a classic case, I think, of kind of the false dilemmas that we're worried about actually not being present. Anand, do you want to jump in here, please?
Yeah, just briefly because of time, but I think it's worth acknowledging that there's a huge intersection with inequalities of health debates here. And one area that we're interested in is really healthcare utilization. And I was just going to reflect on a paper that I think is very interesting in this way, Richard Cookson paper, and it was actually looking at healthcare utilization by income decile in England. And if you think of a country where you have universal access to healthcare, you have large inequalities in life expectancy by income, but you also have large inequalities in healthcare utilization. So what Cookson described was a pro-rich distribution of healthcare quality and a pro-poor distribution of healthcare quantity. So the poor are using more healthcare. Now they're still dying earlier. So there is a challenge here when we're thinking about intervening and shifting towards low carbon models. You know, there is a sort of pro-poor distribution of quantity. So we have to bear that in mind. I think that is a challenge, but just sort of picking up on what Sandy was getting at as well. There's a huge literature on that which we need to tie together.
Thank you. Look, I think that's very valuable. I think what I'm going to do is I'm going to allow us to run just a couple of minutes over before we conclude. I've got an interesting question here from Asim Ahmad, who says, basically, should we need to consider net zero in the context of net zero plus, not only as carbon emission, but waste generation, mainly plastics and consuming huge quantities of water, which in turn affects health of future generations. I mean, I think this comes back to the very concrete example of single use versus reusable. I wonder if the panel could talk about that. Are there any current initiatives around kind of healthcare settings moving back to reusables? I mean, interestingly, in terms of the cultural history of disposability more broadly, my understanding was actually that, you know, for the post-war generation, the idea of disposable products was really anathema, and that it's actually had to be actively promoted by manufacturers to get people on board. Whereas now, I mean, in many settings, you know, it would presumably be considered unhygienic to reuse things with patients. But yeah, I was curious if we could just pick up on that point about initiatives around reusability in areas that we're seeing success.
Myself, I don't know, actually. I have no idea here, because I think, you know, there is a measurement aspect, you know, probably to do any evaluation, but I don't know if any has been done.
Yeah, maybe no research is in this area. Charles, did you want to jump in?
Well, I think that this circular economy lens really is important. You're right to mention this. I mean, I was looking just at the environmental impact, a report that was published by a commission on the ethics of science and technology in Quebec lately on the environmental impacts of digital technologies and artificial intelligence. And one of the first, you know, accelerating factors of the environmental impact is obsolescence. And the fact that things are being produced just to be obsolete within a few years and sometimes months. And that is a critical issue when it comes to the issue of you know, not only the gas emissions, but also pollution and resource use in general. I think that this is something that we need to consider seriously in a context where sure our health systems are being financed by public health systems in a way that's, well, sort of try to get away from that market-based economy, but in the background, the pharmacological industry and the health technology industry generates, you know, it's a big economy. It generates a lot of profits, and all of these pressures, economic and financial pressures, competitions between in a market-based economy puts pressure on the producers to sort of actually have business models that generate profits. So that needs to be taken to account. And I think that Valentina pointed that really well, that these structural changes need to be considered as well. And we need to take a step back from only looking at the healthcare context if we really want to understand the determinants of the environmental impact of healthcare.
Yeah, interesting. Anand.
Yeah, just to add that, I know that there is a lot of work going on to address plastic in healthcare, and this is often led by facilities and other collaboration. So there is a lot of work happening in the background. But I was just going to mention something about the single-use versus reusable materials, because you asked about that specifically. I know that quite a bit of work has gone into looking at this, use life cycle assessments, try and understand whole life cycles of single use and reusable. And in general, what they find, this is work people like Chantal Rizan and others at Brighton and Sussex Medical School. And what they find is that actually reusable has considerably less waste, less plastic, and fewer emissions. Now, one of the challenges is this might require upfront investments, because a lot of facilities have got rid of their sterilization facilities, perhaps competencies as well. I'm not so familiar with the detail, but there needs a system change, a rethink. It's become easier to buy in, burn and destroy. It requires a rethink. But I think there are drivers for this change. But I think from my research perspective, what we need is that dialogue between people on the ground in health facilities, administrators knowing what challenges they face, and then policymakers. And in some settings, you have really good dialogues. It really varies. And I think this is it varies place by place, country by country, but it's that dialogue which is absolutely critical.
Yeah, I think Valentina, I'm just to close the session. I mean, given your research, I just wondered if you had any comments there about the nature of this dialogue that is so crucial between the different actors and the different levels of decision makers in order to ensure that these initiatives are effective.
Sure. To support what was just mentioned and to emphasize on it, the consultation also revealed the importance of thinking on multiple levels. And if a practical theoretical framework was to come out, it should really take, according to them, and I agree, it should take into account the notion of responsibility at different levels, state, public health system, hospitals, and within the doctor-patient relationship. Because the responsibility vary and influence the decisions that are made. And each entity faces different challenges and levels of complexity within these challenges. So what gets funded, what gets manufactured, what is reimbursed, what gets prescribed, and what is sold, and what can people afford, et cetera, et cetera. So it really emphasizes what Anand just said.
Yeah, thank you. Look, that's very, very helpful. I'm just going to look, I think there's much more we could discuss. It's an absolutely fascinating subject. I'm just going to close out the session now. I'll just take a couple of questions really as comments. I mean, a couple of the attendees have noticed that, of course, even though we've talked about health inequalities in the context of the Global South, we're all operating from contexts in the Global North. And of course, it would be interesting in this kind of conversation to have someone who is embedded in that context. So I think, take that as a very apt observation. And look, just to recap, I think the conversation today, we kind of started out, Sandy, talking about the importance of measurement, and I think that's a theme that's come through, that in order to assess and evaluate any of these interventions, we really need to be able to have good data. And as yet, it seems that this kind of question around evaluation and data gathering is really in its infancy. We also talked about, I think, across multiple points in the dialogue, kind of this wider view of what healthcare means. This is about requiring structural change, not just individual changes. This is also about considering healthcare across multiple time spans and generations, and kind of really considering the ethical dimensions of what we owe, not just to current living humans, but future generations. And of course, this also requires a really careful consideration of the different actors involved. I think it was very interesting to hear not just about kind of doctors and patients, but, you know, pharmacists and other ways, to Anand's point about, you know, conceptualizing the causes of health as sort of outside classic healthcare systems. I think another really important theme that's emerged is the importance of disabusing people of assumptions and questioning premises. You know, that there's a framing around this idea of net zero and environmental ethics, that it always means we're going to have to give something up. But actually, there are a lot of positive consequences. We can kind of use net zero and environmental change as a lever to improve outcomes in other dimensions as well. And also that, you know, this is not something that is being imposed on the healthcare system, but actually is bubbling up organically. And perhaps the challenge is not so much to, you know, create frameworks afresh that we then have to push on people, but actually to kind of harness some of that momentum and some of that energy effectively, so as to bridge the gap between, you know, what scholars know needs to be done and then how it can be implemented by policymakers. So thank you all for such a fascinating discussion, and really appreciate all of the participants tuning in, and of course to the Brochet Foundation for hosting us today. So thank you all, and yes, look forward to future discussions. Thanks again.
Thank you.
Bye-bye.
Thanks, everyone.
Bye-bye, everyone.